Hi there, our highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. This video I am about to present was compiled by Dr. Nath Arawa, a clinical pharmacist by training and profession who is the founder of Progressive Pharmacotherapy Consultants, the premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management and optimal clinical outcomes are very crucial and non-negotiable to us. Here we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So, on behalf of the Institute, I humbly urge you all to sit back and spare me part of your very precious time to share with you very useful tips which may prove very, very handy in your line of duty. I now welcome you all to part 249 of our pharmacotherapy series, which majors in infectious diarrhea. The next question reads, PKJ, a 3-year-old girl, is brought to the emergency department because of stomach pains and non-bloody diarrhea that has progressed to bloody diarrhea over the past 48 hours. 5 days before the onset of diarrhea, the family celebrated her birthday at a fast food restaurant. PKJ's parents ate fish sandwiches and PKJ ate a hamburger. PKJ's mother noted that the hamburger was not thoroughly cooked because the juices from the hamburger were still pinkish. PKJ has no significant medical history. During the week, she attended a day care center. On physical examination, PKJ is afebrile, with signs of mild to moderate dehydration. A stool sample is negative for fecal leukocytes. The physician assesses her illness as bloody diarrhea, possibly caused by Shiga toxin-producing Escherichia coli, abbreviated as STEC. The plan is to admit PKJ to the hospital for hydration, observation, and further workup. What clinical and laboratory findings and epidemiologic history are consistent with the diagnosis of Shiga toxin-producing Escherichia coli as the cause of PKJ's illness? E. coli 0157H7 is a strain of Escherichia coli that produces Shiga toxins as one of its mechanisms of causing GI illness. A second virulence factor of STEC strains is their ability to attach to and damage the intestinal mucosa. These E. coli bacteria cause a wide spectrum of illness, including asymptomatic carriage, mild and non-bloody diarrhea, bloody diarrhea, hemorrhagic colitis, HUS, and thrombotic thrombocytopenia purpura. Escherichia coli 0157H7 should be suspected in the setting of abdominal cramps with non-bloody diarrhea that progresses to bloody diarrhea over 1 to 2 days. Unlike bloody diarrhea associated with Shigella species or Campylobacter species, fever is often absent or of low grade because this pathogen is not invasive. Patients with severe illness are more likely to have fever, however. Shiga toxin-producing Escherichia coli is most commonly spread by consumption of undercooked beef products that are contaminated with Escherichia coli 0157H7, although other modes of acquiring this infection have been reported. The incubation period for this infection is usually 3 to 4 days, which is consistent with PKJ's recent history of eating undercooked hamburger. In most instances, the illness resolves in 5 to 8 days. Fecal leukocytes may or may not be found in stool samples. The next question reads, how can PKJ's diagnosis of Escherichia coli 0157H7 infection be confirmed? In the United States, Escherichia coli 0157H7 is the most common STE/C serotype associated with this infection. Unlike other Escherichia coli 0157H7 does not rapidly ferment sorbitol, thus allowing the use of special culture media, sorbitol McConkey, to help in identifying this organism. PKJ's stool should be cultured using this media. Because of other sorbitol fermenting organisms and non-O157 STE/C, further testing for Shiga toxins or the genes encoding them is increasingly performed. The next question reads, 48 hours after admission to the hospital, PKJ is pale and has developed several bruises on her extremities. The nurse recorded only a minimal output of darkened urine during the past 24 hours. New laboratory tests reveal blood urea nitrogen of 150 mg per deciliter. Serum creatinine of 6 mg per deciliter. Serum potassium of 6.8 milliequivalents per liter. WBC count, 20,000 cells per millimeter cubed. Hemoglobin of 5 grams per deciliter. Platelet counts of 50,000 cells per millimeter cubed. And urinalysis is positive for blood and protein. The stool specimen sent on admission is positive for Escherichia coli 0157H7. So my question to you is, what complication of Escherichia coli 0157H7 infection does PKJ now display? The new clinical and laboratory findings support the diagnosis of HUS, a well-known complication of STE/C infection. HUS is characterized by the triad of thrombocytopenia, microangiopathic hemolytic anemia, and acute renal failure with oliguria. On physical examination, PKJ's bruises on her extremities are consistent with thrombocytopenia, which is confirmed by the low platelet count. Her pale appearance is consistent with anemia and is confirmed by the low hemoglobin. The dark urine is caused by the color imparted from bilirubin because of red cell lysis, hemolytic anemia. Finally, PKJ's decreased urine output and increased serum creatinine and BUN concentrations are consistent with renal failure. PKJ has several risk factors for HUS. Her age, i.e., children aged 65 years, and treatment with antimotility or antidiarrheal agents, although this has not been universally confirmed. The progression of Escherichia coli 0157H7 gastroenteritis to HUS typically becomes apparent about 1 week after the onset of diarrhea. Of children, 3% to 7% may develop HUS, with a mortality rate ranging from 3% to 5%. In adults, Escherichia coli 0157H7 infection progresses to HUS in as many as 27% of patients, with a higher rate in patients above 65 years of age. HUS-related mortality has reached 42% in patients above 15 years of age. Elderly nursing home patients have a mortality rate of up to 88%. The next question reads, would PKJ benefit from drug therapy, including antimicrobial, antimotility, or antidiarrheal agents? Other than supportive measures to manage the complications associated with illness caused by Escherichia coli 0157H7, no specific drug therapy for this infection exists. In retrospective and prospective studies, antibiotics have not influenced the severity of illness, or the duration of diarrhea or other GI symptoms. When TMPSMX was started a mean of 7 days after the onset of diarrhea, the duration of Escherichia coli 0157H7 excretion was not altered. The effect of antibiotic administration on the risk of Escherichia coli 0157H7 complications, e.g., HUS, remains controversial. A prospective cohort study of 71 children with diarrhea caused by Escherichia coli 0157H7 found that antibiotic treatment increased the risk of progression to HUS. Previous publications have supported these findings, whereas others have reported that antibiotics do not increase the risk of progression to HUS. A systematic review of these and other studies revealed no association between antibiotic administration and development of HUS. Antibiotic selection, dosing, timing of administration, small sample sizes, and a lack of placebo use in the selected studies complicate the analysis. Thus, the role of antibiotics in the treatment of Escherichia coli 0157H7 infection remains controversial. Currently, clinicians do not recommend antibiotic treatment for STEC, though active U.S. surveillance reports nearly two-thirds of patients with this diagnosis receive antimicrobial therapy, including 29% of patients receiving therapy after confirmed diagnosis. Despite these numbers, PKJ should not receive antibiotic therapy at this time. Clinicians must carefully weigh empiric antibiotic treatment before an organism has been identified. Antimotility drugs are not recommended for patients with Escherichia coli 0157H7 infection because they have been variably associated with an increased risk of progression to HUS, although other studies have failed to find an association. Despite these concerns, recent reports suggest up to 31% of patients continue to receive antimotility agents for this infection. Although the explanation for the increased risk is unknown, the reduction of bowel motility may decrease the clearance of organisms from the GI tract, thereby increasing the absorption of toxins. Administration of antimotility drugs within the first 3 days of illness has been associated with a longer duration of bloody diarrhea. The next question reads, PKJ's family members want to know what they could have done to prevent this infection. So my question to you is, on discharge from the hospital, is it safe for PKJ to return to her daycare center? STEC is often spread to humans by consumption of contaminated beef products that are not thoroughly cooked. Because thorough cooking kills this organism, meat should be well cooked, i.e., juices from meat should be clear, not pink. In addition, this infection can be acquired by consuming other contaminated foods, including water, unpasteurized milk, apple cider, lettuce, and sprouts. Finally, because contact with infected persons commonly results in transmission of this infection to others, PKJ should not return to daycare until at least 48 hours after her diarrhea has ceased. The next question reads, BMW, a 35-year-old woman, is admitted to a 10-bed medical ward for the treatment of Streptococcus pneumoniae meningitis. On arrival, she is started on ceftriaxone, Rocephin, 2 grams IV every 12 hours and improves over the next few days. On day 7 of antibiotic therapy, she complains of feeling warm, with cramping abdominal pain and diarrhea. She begins passing mucoid, greenish, foul-smelling watery stools, and has a temperature of 101 degrees Fahrenheit. Microscopic examination of a stool sample is positive for fecal leukocytes. The physician's assessment of BMW's clinical and laboratory findings is antibiotic-associated diarrhea, abbreviated as AAD, most likely caused by Clostridioides difficile. So my question to you is, what is the most likely mechanism for this patient's antibiotic-associated diarrhea? Antibiotic-associated diarrhea is a common complication of antimicrobial therapy. The mechanisms by which antibiotics cause diarrhea include direct allergic and toxic effects on intestinal mucosa, and alterations of GI motility, e.g., erythromycin, and of normal intestinal flora. Changes in the normal bowel flora can lead to changes in carbohydrate or bile acid metabolism by intestinal bacteria or to overgrowth of pathogenic bacteria, either of which may be followed by diarrhea. Bacteria known to be associated with antibiotic-associated diarrhea include Clostridium perfringens, Staphylococcus aureus, Klebsiella oxytoca, Candida species, and Clostridioides difficile. Clostridioides difficile infection, abbreviated as CDI, is the most clinically relevant microbial cause and the focus of this section. A spore-forming, gram-positive anaerobic bacillus, Clostridioides difficile, can cause a wide spectrum of syndromes, including asymptomatic carriage, diarrhea of varying severity, colitis with or without formation of pseudomembranes, toxic megacolon, colonic perforation, and death. The pathogenesis of Clostridioides difficile infection involves disruption of the normal colonic flora, most commonly by antibiotics. An increasing number of cases in the outpatient setting have been identified without any antibiotic exposure, making additional risk factors difficult to find. Recent data suggest that proton pump inhibitors may be responsible for Clostridioides difficile infection. Alteration of the colonic microflora is followed by overgrowth of toxin-producing strains of Clostridioides difficile. These toxins, primarily toxins A and B, are responsible for causing colonic inflammation and the clinical manifestations of this infection. A highly pathogenic strain of Clostridioides difficile has been described in outbreaks in the United States and around the world. This strain, labeled BINAP1 or ribotype 027, generally causes more severe disease. Among its increased virulence factors are an increased production of both toxins A and B and a binary toxin. This ribotype has become endemic in some facilities and appears to cause more severe disease even in non-outbreak situations. The next question reads, why is BMW's history and presentation consistent with antibiotic-associated diarrhea caused by Clostridioides difficile? BMW's major risk factor for acquiring Clostridioides difficile infection is her receipt of an antibiotic within the last 2 weeks. Clostridioides difficile is a common cause of nosocomial diarrhea. The clinical and laboratory findings consistent with Clostridioides difficile infection include mucoid, greenish, foul-smelling watery stools and crampy abdominal pain. Patients usually present with low-grade fevers, but temperature may be above 104 degrees Fahrenheit. Peripheral leukocytosis is common with Clostridioides difficile infection, sometimes with WBC above 30,000 cells per millimeter cubed. Fecal leukocytes are variably present in Clostridioides difficile infection and are not clinically useful for diagnosis. The onset of symptoms of Clostridioides difficile infection varies widely from a few days after the start of antibiotic therapy to 8 weeks after the agent is discontinued. Other risk factors for acquiring Clostridioides difficile infection are admission to a hospital in which Clostridioides difficile is endemic or in which there is an ongoing outbreak of Clostridioides difficile infection. The next question reads, how can BMW's diagnosis of Clostridioides difficile infection be confirmed? Finding toxins in unformed stool of symptomatic patients is the gold standard for diagnosis. Older enzyme immunoassays detecting toxins A or B have largely been replaced by polymerase chain reaction (PCR) tests, because PCR is much more sensitive. An advanced two-step diagnostic method is increasingly recommended. The two-step test first looks for the presence of glutamate dehydrogenase, abbreviated as GDH, antigen as a quick and inexpensive screening test. Glutamate dehydrogenase is produced by all Clostridioides difficile strains, so positive glutamate dehydrogenase tests are then followed by toxin-detecting PCR. Samples negative for glutamate dehydrogenase are considered negative and not tested further. Culture, though helpful, is complicated by the fact that of the Clostridioides difficile strains isolated from various populations, 5% to 25% do not produce toxins, that is non-toxigenic, and do not cause colitis or diarrhea. Routine testing for specific Clostridioides difficile strains such as ribotype 027 is not typically available in most settings. Colonoscopy with biopsy is used to make the diagnosis of Clostridioides difficile colitis rapidly. The characteristic colonic changes are raised, yellowish nodules or plaque-like pseudomembranes, often with skip areas of normal mucosa. Because the characteristic pseudomembranes may be scattered throughout the colon, the diagnosis of pseudomembranous colitis can be missed with colonoscopy. The next question reads, how can BMW's Clostridioides difficile infection be differentiated from enigmatic antibiotic-associated diarrhea? Only 10% to 20% of cases of antibiotic-associated diarrhea are positive for toxigenic Clostridioides difficile. The remaining cases have an unknown cause and are referred to as simple, benign, or nuisance diarrhea. The clinical resolution of benign diarrhea is a self-limited illness that resolves with nonspecific supportive measures and discontinuation of antibiotics. These clinical entities can be differentiated from one another by several objective measures. In hospitalized patients, watery diarrhea, low functional capacity, acid suppression, low albumin, and a WBC above 13,000 cells per millimeter cubed were significant predictors of Clostridioides difficile infection. Other clinical features that suggest Clostridioides difficile infection rather than enigmatic diarrhea are constitutional symptoms, lack of an antibiotic dose relationship to the illness, and hospital-wide epidemics of diarrhea. The next question reads, BMW's stool sample is positive for both glutamate dehydrogenase and Clostridioides difficile toxin. So my question to you is, what is the general plan to treat BMW's Clostridioides difficile infection? After replacement of fluids and electrolytes, there are several steps to most effectively manage BMW's Clostridioides difficile infection. The first is to discontinue the offending drug, if possible, which in BMW's case is probably the antibiotic ceftriaxone. While some data suggest that withdrawal of the precipitating antibiotic and supportive care may be sufficient for mild disease, all available guidelines suggest specific antimicrobial treatment. Because BMW is being treated for bacterial meningitis, a life-threatening infection, discontinuing antibiotics is not an option. A second option is to change her antimicrobial therapy to an agent less likely to cause Clostridioides difficile infection. BMW is taking a cephalosporin, which, as with ampicillin, amoxicillin, and clindamycin, is frequently implicated as a cause of Clostridioides difficile diarrhea. In contrast, antibiotics, such as TMP-SMX, and aminoglycosides, are less commonly associated with Clostridioides difficile infection. None of these antimicrobials, however, is a suitable alternative for treating Streptococcus pneumoniae meningitis. BMW should also receive therapy directed against Clostridioides difficile while continuing to take ceftriaxone for the treatment of her bacterial meningitis. The next question reads, what antibiotic should be selected to treat BMW's Clostridioides difficile infection? The oral agents most commonly used to treat Clostridioides difficile infection are metronidazole and vancomycin. The differentiation between these two agents is complex and evolving, but it is guided in part by severity of illness. The most optimal definition of severe disease is not well established, but general markers of instability of vital signs with high white counts and changes in albumin and serum creatinine are suggested. In patients categorized as having mild to moderate disease severity, metronidazole is generally recommended as the preferred initial agent. In a randomized trial that enrolled patients with Clostridioides difficile infection and colitis, no significant difference was found in the efficacy of these drugs after 10 days of treatment. Overall, over 95% of patients treated for a first episode of Clostridioides difficile infection with oral metronidazole or vancomycin are expected to respond to therapy. Recent reports have shown increases in Clostridioides difficile resistance to metronidazole and vancomycin, but the clinical significance in treatment selection is unknown. Antibiotic sensitivities, therefore, are not routinely performed on Clostridioides difficile. Metronidazole is well absorbed after oral administration and is excreted through the biliary tract before reaching the colon. Common adverse reactions include nausea, vomiting, diarrhea, dizziness, confusion, and an unpleasant metallic taste. A disulfiram-like reaction can occur when alcohol or alcohol-containing medications are taken concurrently with metronidazole. Because metronidazole is a carcinogen and, in some animal species, a mutagen, it should be used in pregnancy only if clearly needed. Similarly, metronidazole's safety in children has not been proved, and many prefer not to use it in this population if other options exist. Oral vancomycin produces fecal concentrations that are several 100 times the concentration needed to inhibit toxin-producing strains of Clostridioides difficile. A 10 to 14-day course of oral vancomycin 125 to 500 mg orally 4 times daily is recommended for the treatment of Clostridioides difficile infection, with all dosing regimens equally effective in the patients studied. Because of equal efficacy and high concentrations in the colon with all doses, vancomycin 125 mg is the most commonly prescribed dose. Although oral vancomycin is not well absorbed, measurable serum concentrations have been found in patients with both normal and compromised renal function, though higher and longer dose regimens, severe infection, and renal dysfunction were more associated with serum concentrations. Fidaxomicin is the newest antimicrobial indicated for the treatment of Clostridioides difficile infection. Fidaxomicin is a macrocyclic antibiotic active against Clostridioides difficile that is poorly absorbed and achieves high colonic concentrations. It has limited antimicrobial spectrum and largely preserves colonic flora. In the primary clinical trial, patient outcomes on initial infection were similar when compared with vancomycin. This finding, along with a significantly higher cost of therapy, has led many clinicians to suggest fidaxomicin be reserved as second-line therapy. However, one potential advantage for fidaxomicin was in recurrence rates, which were found to be significantly lower with fidaxomicin compared to vancomycin, 15.4% versus 25.3%, with a p-value equal to 0.005. While recurrence is a concern in Clostridioides difficile infection treatment, it is not yet clear if it is possible to identify patients for whom the higher cost would provide an additional benefit from this effect. Because BMW is not critically ill, metronidazole, dosed at 500 mg orally 3 times daily, for 10 to 14 days is recommended as first-line treatment. Oral metronidazole and oral vancomycin are generally considered equally efficacious in mild to moderate disease, but vancomycin use should be limited to prevent emergence of vancomycin-resistant organisms. In addition, oral vancomycin capsules are significantly more expensive than a course of oral metronidazole. Some of this cost differential can be offset by using the IV vancomycin preparation to prepare an oral solution which can be flavored and prepared as directed in the package insert. Once therapy directed against Clostridioides difficile is initiated, diarrhea or cramping should subside within 2 to 4 days. If BMW's symptoms have not resolved, vancomycin can be tried. We will now discuss alternative therapies. Let's begin with toxin binders. Traditional anion-binding resins, e.g., cholestyramine and cholestipol, are not as reliable or as rapidly effective as oral metronidazole or vancomycin and are not recommended as routine therapy. Next we will look at probiotics. Using probiotics introduces probiotic microorganisms into the normal flora to counteract disturbances and reduce the colonization with pathogenic species. Although orally administered, Lactobacillus species and the yeast Saccharomyces boulardii have been used to treat Clostridioides difficile infection. No data support the use of probiotics alone. Adjunctive use has been suggested to prevent Clostridioides difficile infection and its recurrences. A hospital trial looking at prevention of all antibiotic-associated diarrhea with lactobacillus reported positive results for the prevention of Clostridioides difficile infection. The results of that study, however, are tempered by the methodological exclusion of patients receiving antibiotics with a high risk of causing Clostridioides difficile infection, making generalization to other patient groups difficult. The exact role of probiotics in treatment or prevention of Clostridioides difficile infection is not yet known. Adding further caution to the widespread use of probiotics, reports of isolated adverse effects, including fungemia, with ingestion of viable Saccharomyces boulardii have been reported. The next question reads, should BMW be given any antidiarrheal agent to relieve her symptoms? Opiates and other antiperistaltic agents should be avoided in patients with Clostridioides difficile infection. Although these types of drugs may relieve diarrheal symptoms, they may also delay toxin removal from the GI tract. Evidence supporting these negative effects is minimal as data are scarce, but caution would suggest avoiding any antimotility agent in BMW. The next question reads, following resolution of BMW's Clostridioides difficile infection, is it necessary to send a follow-up stool sample to determine whether it is negative for Clostridioides difficile toxin? After resolution of diarrhea, obtaining a follow-up stool sample to determine whether it is negative for Clostridioides difficile toxin is not recommended as part of routine practice because most patients with positive tests will not develop a recurrence of the diarrhea. In addition, up to 3% of healthy adults carry small numbers of Clostridioides difficile in their feces, whereas colonization rates are much higher, 31% to 37%, in hospitalized patients and infants under 1 month. So there you have it, our highly esteemed viewers and listeners. That brings us to the end of this video. If it benefited you in any way, kindly remember to give it a thumbs up, to like it and to share it widely with your peers. Please leave your comments at the bottom. And if you haven't yet done so, I humbly urge you to subscribe to our YouTube channel. I would like to promise you all that the very, very best is yet to come. Thank you very much for viewing this video. On behalf of our senior colleague, Dr. Nath Arawa, I sincerely appreciate your partnership, continued support and kind collaboration. We look forward to interacting with you in the next video, which will be part 250.